Picture this. You're planning your dream wedding, right?
Okay.
You've got the perfect palace venue booked in Udaipur, India. You have this stunning designer lehenga ready to go.
Yeah.
You're checking off all the traditional bridal prep.
Like the facials, the body sculpting, all of that.
Exactly, getting that perfect glow. But then right there on the menu of pre-wedding wellness treatments, sandwiched between like skincare and a massage, is something called the orgasm shot.
Oh, wow.
Yeah. It's being actively pitched to these brides as a way to guarantee a better honeymoon. So today, our mission for this deep dive is to uncover the truth behind this wildly popular, highly marketed treatment. Like, can a single injection actually increase libido and cure female sexual dysfunction? Or is the marketing hype just completely outpacing the medical science?
It really is. It highlights this massive collision we're seeing right now between aggressive, high-end cosmetic marketing and a really highly complex area of human biology.
Right.
And we're looking at a fascinating cross-section of sources today to figure this out for you. We have, news reports on these bridal trends, clinical guidelines from major medical bodies, critical reviews from gynecologists.
And we even have that clinical pilot study, right?
Yeah, published by the very doctor who invented and trademarked the procedure itself.
Which is going to be wild to get into.
Yeah.
But to truly evaluate if this shot can increase libido, we have to start by stripping away the clever branding.
Absolutely.
We have to look at the raw biological mechanics. Because before we can talk about mind-blowing orgasms, we need to talk about blood.
Yes, we do.
Because this isn't a drug manufactured in a lab. The primary ingredient actually comes straight from you.
Right. That's the foundational concept here. The O shot utilizes a process called platelet-rich plasma, or PRP.
Right, PRP.
And the fundamental science of PRP is actually well established in other fields, like orthopedics for joint injuries or dermatology for wound healing.
Okay, so how does it actually work in practice?
Well, the process starts simply enough. A clinician draws a small amount of your own blood, usually just from your arm.
Okay, pretty standard.
Yeah. And then they place that vial into a centrifuge, which is a machine that spins it at extremely high speeds. The centrifugal force separates your red blood cells from your plasma.
Gotcha.
So that allows them to isolate this concentrated yellowish fluid, and that fluid is absolutely packed with your body's platelets.
So we're basically isolating the body's natural microscopic repair crew.
Exactly. Think of it as a concentrated dose of healing signals. Platelets contain specific proteins called growth factors.
Right.
Two of the major ones are vascular endothelial growth factor, or VEGF, and platelet-derived growth factor. So when this concentrated plasma is injected back into the body...
Which in the case of the O shot means injections directly into the clitoris, the labia, or the anterior vaginal wall, right?
Exactly. These growth factors get to work. Their primary biological job is to trigger something called angiogenesis, which is just the formation of brand new blood vessels.
Okay, new blood vessels. That sounds good.
Yeah, and they also stimulate nerve regeneration and boost the production of collagen and elastin. So the end goal is really to improve tissue thickness, elasticity, and localized blood flow.
Okay, I mean, I love the idea of a microscopic repair crew going in and building new blood vessels. That sounds amazing. But wait, let's think about this logically for a second.
Sure.
If I scrape my knee, it heals because it's a localized physical injury. I apply a bandage, the platelets rush to the spot, they do their job, and the skin is fixed.
Right.
But low libido isn't a scraped knee.
No, it is not.
It's incredibly complex. It's neurological, it's emotional, it's hormonal, it's tied to your relationship, your stress levels. I mean, how on earth can a localized injection of platelets fix a system-wide, multifaceted issue like low libido?
Well, you've hit on the core of the controversy right there. The biological mechanism of PRP is strictly structural. It aims to restore lost physical function.
Lost function.
Okay. Yeah, so if a woman has scar tissue from a tear during childbirth, or she's dealing with thinning, fragile vaginal tissue due to, say, a severe drop in estrogen during menopause.
Right, the physical stuff.
Exactly, or even a chronic skin condition like lichen sclerosus. In those specific cases, PRP might theoretically help regenerate that damaged, localized tissue.
So it's fixing the hardware, essentially. If the physical structure is damaged, the platelets try to rebuild it.
Precisely. But it cannot touch the software. If a woman has never experienced an orgasm in her life, which is a condition known as primary anorgasmia, that is often a neurological or psychological reality.
So a needle full of platelets isn't going to fix that.
Right. A local injection of platelets is not going to magically forge a brand new neurological pathway in the brain that never existed. It can't resolve a deep-seated relationship conflict. It can't erase the exhaustion of chronic stress.
And it certainly cannot balance your hormones.
Exactly.
Which makes me circle right back to those young brides in Udaipur. If the actual biological theory of PRP only addresses localized physical damage or aging, thinning tissue, why on earth is it being aggressively marketed to presumably healthy young brides as a quick fix for honeymoon orgasms?
Well, that aggressive pivot from a theoretical regenerative therapy to a mainstream cosmetic lifestyle trend is exactly where the medical community starts raising serious red flags.
I bet.
When we look at the consensus from major regulatory and medical bodies, the picture is really stark. The National Health Service in the UK, the Royal College of Obstetricians and Gynecologists, the FDA in the US.
But none of them endorse it, right?
None of them. They do not endorse the O-shot as a proven first-line treatment to increase libido or treat female sexual dysfunction.
And our sources from the Times of India echo this really loudly. Like doctors on the ground, like Dr. Duhi Jain and Dr. Kripti Rahija, emphasize that there are 0 high-quality, large-scale randomized trials proving the O-shot actually does what the marketing claims it does for libido.
Yeah.
They consider it entirely experimental, like it's not routine gynecological care. While some women do report an increase in libido, the treatment has no formal recognition, and its effectiveness is essentially unproven.
And the lack of robust evidence becomes a massive issue when you look at how it's being sold directly to consumers.
Right, on Instagram and TikTok.
Exactly. Clinics bypass traditional medical consultation by advertising heavily on social media. They lean hard into the word natural because, well, the procedure uses your own blood.
Sure.
But the implication there is that natural and non-surgical automatically mean risk-free, which is false. Any injection in such a highly sensitive vascular area carries risks of pain, swelling, bruising, infection, and sometimes temporary or altered sensation.
Which brings up Dr. Jen Gunter, who is a very vocal gynecologist and a critic of these types of intimate aesthetic trends. She was quoted in our Healthline source with a pretty perfect summary.
What did she say?
She said the O-shot sounds great on paper. Nature's healing. Except there is very little proof that it helps anything.
Yeah, that sums it up perfectly.
And the sheer logistics of getting this unproven treatment are wild for you to consider. We are talking about out-of-pocket costs ranging anywhere from $1,200 to $2,500. It's rarely covered by insurance because it's deemed cosmetic.
And add to that, cost a very strict, often overlooked rule regarding the recovery period.
Oh, this part blew my mind.
Right. Patients are told they must absolutely avoid NSAIDs medications like ibuprofen, Advil, or aspirin for at least 7 days before and after the procedure.
Wait, let me make sure I understand this. You go in, you pay $2,500 for an incredibly sensitive injection down there.
Yeah.
Naturally, you might have some pain or cramping afterward, but if you take a single Advil to deal with the pain, you ruin the treatment.
Essentially, yes, because NSAIDs work by reducing inflammation. But the whole point of injecting concentrated platelets is to trigger a localized, controlled inflammatory response.
To kickstart the healing cascade.
Exactly. If you take an anti-inflammatory drug, you chemically deactivate the platelets. You're effectively stopping the very growth factors you just paid thousands of dollars to inject.
That is mind-boggling. You could blow your entire wedding budget and nuke the results with an over-the-counter headache pill.
You really could.
But this forces a really big question. If the major medical bodies say the evidence is weak, if it costs thousands of dollars, and if it's that fragile, why are there glowing testimonials everywhere online? You look this up, and there are countless women swearing it changed their lives and saved their marriages. Are they all just lying?
No, not at all. Their experiences are likely very real.
Right.
But the source of that improvement largely comes down to the placebo effect.
Ah.
And the placebo effect is incredibly powerful, particularly in the realm of sexual health. Our sources include a meta-analysis that looked specifically at clinical trials for female sexual dysfunction.
What do they find?
The researchers found that in these trials, the placebo effect accounted for a massive 67% of the score improvement. 67%. So more than 2/3 of the benefit these women are feeling in clinical trials comes from the expectation of the treatment working, not the actual drug or procedure being tested.
Exactly. When you combine human psychology with physical arousal, expectation is everything. Imagine someone paying thousands of dollars for a highly anticipated, trendy treatment.
Right.
They go through this intense clinical ritual, having their blood drawn, watching it spin in a machine, enduring a highly sensitive injection. The psychological buildup is
Yeah,
enormous.
you're super focused on the outcome.
Because sexual arousal is so deeply tied to our central nervous system and our mental state, that massive expectation can literally translate into increased physical arousal, more focus during intimacy, and higher subjective satisfaction. The brain is the most powerful sexual organ, and the O-shot is, well, it's a very expensive way to hack it via placebo. That makes total sense. We've got this controversial, expensive procedure that leans heavily on the placebo effect to boost libido. But to truly understand how far these claims can go, we have to look at the research conducted by the actual inventor of the procedure, Dr. Charles Ronels.
Oh, yes.
Because he didn't just stop at blood platelets.
No, he didn't. His recent pilot study is one of the most fascinating inclusions in our sources today because it pushes the boundaries of this treatment far beyond regenerative medicine. He recognized that PRP alone might be inconsistent, so he introduced a completely different element to try and force a physical reaction.
Right. He published a study involving a tiny group of women, just 13 participants, and instead of just injecting their blood platelets, he injected incobotulinum toxin A directly into the clitoris. Now, for anyone who doesn't recognize that long scientific name, that is Botox.
It is a bold, highly counterintuitive mechanism.
Counterintuitive is an understatement. I mean, when I think of Botox, I think of paralyzing forehead wrinkles so they don't move, or numbing a nerve to stop a severe migraine. How on earth is paralyzing a muscle supposed to increase sexual pleasure and boost libido? It sounds like the exact opposite of what you'd want.
Under normal circumstances, Botox is indeed used to attenuate or dampen a response, like relaxing a spasming bladder or dulling persistent pain. But Dr. Runel's theory relies on a different nervous system pathway entirely.
Okay, walk me through this.
To understand it, we have to look at autonomic nerve tone. You have your sympathetic nervous system, which is your fight or flight response. When that's active, it constricts blood vessels to push blood to your major muscles.
Because you're getting ready to run away from a bear.
Exactly. Then you have your parasympathetic nervous system, which is your rest and digest system, and that is responsible for relaxation and physical arousal.
So the sympathetic system is basically an alarm system that clenches everything up, including the blood vessels in the pelvis.
Right. Dr. Runel's theory is that injecting Botox into this specific area blocks the sympathetic nerve tone. It essentially unplugs that localized alarm system.
Wow, okay.
By blocking the sympathetic tone, the relative parasympathetic tone becomes dominant. This shift theoretically causes significant vasodilation. It relaxes the smooth muscle of the arterioles, allowing a massive rush of arterial blood flow into the clitoris.
That is fascinating.
Interestingly, this relies on a very similar end goal to how PDE5 inhibitors, like Viagra, work for erectile dysfunction in men, forcing vasodilation to increase engorgement.
Right, and the results he reported in this 13-woman study are absolutely staggering. According to his data, the Women's Female Sexual Function Index scores, which measure, like, desire, arousal, lubrication, orgasm, and overall satisfaction, they jump from an average baseline of 20.35 up to 30.56.
A huge jump.
Huge. And when the Botox was combined with the PRP, the benefits reportedly improved by an additional 50%.
We do have to look closely at the side effects reported in that same small cohort, though. The vasodilation and nerve changes were so intense for some participants that it went far beyond a simple boost in libido.
Oh yeah, the side effects.
Women in the study experienced spontaneous orgasms, ejaculatory orgasms, and a state of hypersexuality that interrupted their normal daily activities for an entire week.
I mean, spontaneous orgasms interrupting you while you're at work or getting groceries, that sounds incredibly intense and, frankly, a little terrifying if you aren't prepared for it.
Very true.
But let's pause and apply some serious critical thinking here. The guy who trademarked the O-shot, who licenses the name out to other clinics for profit, is the exact same person publishing a pilot study of only 13 women claiming these miraculous, off-the-charts results using Botox.
Right.
As a listener, you have to look at that and be incredibly skeptical of the data.
From a purely scientific standpoint, a study of 13 women is just a pilot. It's a microscopic sample size. And more importantly, it lacks a double-blind, placebo-controlled structure.
which we just learned is huge here.
Exactly. When the inventor of a trademarked, highly lucrative procedure is the primary author publishing data without robust, independent replication from outside researchers, the inherent risk of bias is massive.
You just can't trust it on its face.
No, you can't. The British Association of Aesthetic Plastic Surgeons, or the BAE, actually issued a strong warning in our sources regarding this exact type of commercial ecosystem. They stated very clearly that while exploring women's sexual well-being is vital, the treatments offered to the public must be free of misleading or marketing hyperbole.
Marketing hyperbole. That perfectly captures the massive gap between a tiny, flawed, 13-person pilot study and a slick Instagram ad promising a bride the perfect honeymoon.
It really does.
But it makes you wonder, if this stuff is so experimental, so expensive, and so heavily criticized by mainstream medical bodies, why is there such a massive booming market for it? I mean, why are intelligent women seeking this out in the first place?
They seek it out because the traditional medical system has largely failed them. If we look at the historical context provided in our sources, there is a glaring systemic disparity in how sexual medicine is treated between genders. Men currently have over 20 FDA-approved drugs and devices specifically designed to treat sexual dysfunction by directly targeting the genitalia.
Over 20. And how many FDA-approved drugs do women have?
2, flibanserin and bremelanotide. And neither of them work locally on the genitalia.
Wait, really?
Really? Both are psychoactive medications that target neurotransmitters in the brain to treat hypoactive sexual desire disorder. Women currently have 0 FDA-approved drugs that directly target female genitalia to improve physical arousal or orgasm.
That is a staggering gap. Why is the disparity so massive? Are female bodies really that much harder to study?
It's less about biology and more about a historical double standard at the FDA level regarding how they measure a drug's success.
Yes.
For a male sexual dysfunction drug like Viagra to be approved, the historical benchmark was simply proving objective physical changes. Did the drug create a measurable firmness of an erection? It was a strictly mechanical physical measurement.
Okay, straightforward enough.
But for a female sexual dysfunction drug to get approved, the FDA required proof of an increase in subjective psychological satisfaction.
What? So it's like grading men on simple attendance. Did the physical reaction show up for class? But grading women on a complex, highly subjective essay about their emotional state.
That's a perfect analogy.
If a female drug works, and her physical arousal dramatically improves, but she happens to be stressed about her job that week and still reports low overall satisfaction on her questionnaire,
Yeah.
the drug fails the trial.
Yes.
No wonder pharmaceutical companies don't want to invest billions in female libido drugs. The bar for success is totally different.
That double standard disincentivized decades of research, leaving women with very few evidence-based, FDA-approved options. And nature always fills a vacuum.
So the cosmetic clinics swoop in.
Exactly. When traditional medicine tells a woman dealing with distressing sexual symptoms that there's no pill for her, the commercial market rushes in with trademarked, out-of-pocket procedures like the O-shot. Women aren't spending thousands of dollars because they are gullible.
Right.
They're doing it because they are seeking help for genuine distress, and the established medical community often leaves them empty-handed.
But the established medical community isn't entirely empty-handed, are they? Our sources from the British Menopause Society and the pelvic specialists outline several evidence-based alternatives that actually are proven to help women experiencing low libido or physical discomfort. What should someone actually be looking into if they want to avoid the experimental injections?
The first, most critical step is a comprehensive biopsychosocial assessment. Because female libido is such a complex interplay of biology, psychology, and social factors, you have to rule out systemic disruptors.
Yeah.
For instance, many SSRI antidepressants frequently blunt libido as a side effect. You have to address underlying relationship dynamics, too. And if the issue is primarily hormonal, specifically a distressing chronic lack of desire known as hypoactive sexual desire disorder, the British Menopause Society supports the off-label use of testosterone replacement therapy.
Wait, testosterone, most people hear that and think of bodybuilders or male hormone replacement. How does that help female libido?
Well, testosterone is actually essential for both sexes. Premenopausal women produce their own testosterone, and it plays a vital role in modulating sexual behavior by interacting with the central nervous system.
Interesting.
It helps regulate dopamine, the neurotransmitter responsible for desire and reward. When testosterone levels drop, particularly during menopause, replacing it, typically at about 1/10 of the standard male dose, can significantly reignite that neurological desire pathway.
Okay, and what about the physical hardware issues we talked about earlier? The thinning tissue, the dryness, the pain during sex.
For those specific structural issues, often diagnosed as genitourinary syndrome of menopause, the gold standard evidence-based treatment recommended by NICE guidelines is topical estrogen.
Oh, just a cream.
Yeah, exactly. When estrogen drops during menopause, the vaginal and vulvar tissues are literally starved of the hormone they need to maintain thickness and moisture. Applying localized estrogen directly feeds that tissue, safely restoring its elasticity and health without the need for thousands of dollars in platelet injections.
That sounds way more practical.
It is. Additionally, for physical pain or tight muscles, specialized pelvic floor physical therapy is highly effective. And for the psychological or relational hurdles, dedicated psychosexual therapy is paramount.
So pulling all these threads together, what does this actually mean for you, the listener? If you are wondering if the O-shot is the magic bullet for libido, here is the takeaway. The O-shot utilizes real biological mechanics. Platelet-rich plasma absolutely aids in tissue healing. If you have specific, localized physical issues like post-childbirth scarring or a diagnosed condition like lichen sclerosus PRP might be a legitimate, albeit experimental tool to help restore lost physical sensation.
But as a quick fix to inherently increase libido, or as a heavily marketed pre-wedding cosmetic trend to guarantee a better honeymoon, the claims completely outpace the scientific evidence.
Yep.
The placebo effect dominates this space, and the lack of large-scale independent trials should give anyone pause before spending thousands of dollars out of pocket. If you are experiencing a distressing drop in libido, remember that you are navigating a complex biopsychosocial system. You deserve a thorough, evidence-based assessment of your hormones, your medications, and your pelvic floor, rather than being sold a trademarked quick fix. Your best defense is informed consent.
It really is. It's about taking a step back from the glossy Instagram ads and demanding actual science and real solutions for women's bodies. Which leaves us with a final thought for you to mull over today.
Yeah, what's the big takeaway question?
We talked about that glaring double standard at the FDA, how men's treatments were historically judged on straightforward physical mechanics, while women's treatments were judged on complex psychological satisfaction. If the FDA suddenly changed its criteria today and decided to measure women's sexual dysfunction treatments strictly by physical changes, exactly like they do for men, how many of these experimental, localized procedures would instantly flood the mainstream approved market?
That is a fascinating question.
And more importantly, would a purely physical metric actually be a victory for women's healthcare? Or just a dangerous oversimplification of female pleasure?